So, hello everyone. Today I'm going to talk about the adrenergic agonist. As you all know, we were discussing the sympathetic drug acting autonomic from autonomic nervous system. Autonomic, we already did explain the parasympathetic drug acting on parasympathetic nervous system, parasympathomimetic and parasympatholytic, and other cholinergic agonist and cholinergic antagonist. This chapter is about the adrenergic. We will discuss the sympathetic acting on sympathetic nervous system, and in sympathetic nervous system, we will discuss the uh, sympathomimetic drugs as well as the sympatholytic drug, the adrenergic agonist and adrenergic antagonist. So the first is about the adrenergic agonist. So adrenergic agonists are the drugs that stimulate the adrenergic receptors and produces responses. So this is the synthesis. As you know, we did explain what kind of neurotransmitter that communicate in the sympathetic nervous system and stimulate the produces the intracellular responses in the sympathetic nervous system and the adrenergic fibers. So before that how these neurotransmitters are synthesized in the adrenergic neurons. So the tyrosine is in the parasympathetic, that was cholinergic. Here, this is the tyrosine. Tyrosine enter into the sodium tyrosine transporter systems. Here, when it goes to the pre-adrenergic fiber, so it converted into the dopamine through hydroxylation of the tyrosine occurs, and it formed the dopa is then they form dopamine, and dopamine is then enter into the vesicle. So and then they are, whenever a stimulus comes, they fused with the neuroterminal, the pre-synaptic neuroterminals, and release the norepinephrine into the synaptic cleft, where the synaptic cleft where we have the effector organs receptor like the alpha receptor, the beta receptors are present, synaptic and the postsynaptic terminals, and what happens when intracellular responses are fused. Norepinephrine, as I mentioned, that monoamine oxidases, these are the enzymes that oxidize these dopa and dopamine and become inactive metabolites and can be excreted. So you can stop the synthesis of the dopa and dopamine. As a result, the norepinephrine synthesis can be stopped over here. One mechanism is here. Second, here whenever the norepinephrine comes to the synaptic cleft, here we have the catechol, the COMT, corticomethyl transferases, where methylation of these norepinephrine occurs and it becomes inactive metabolites that can be excreted. There are some reuptake mechanisms where the reuptake by the presynaptic neuroterminal neurofiber, and that is again enter into the neurofibers, and again it forms vesicles and store vesicles and then released here in the presynaptic membrane. Here, this is also can be oxidized by monoamine oxidases, the enzymes that can oxidize the norepinephrine over here. There are also the alpha 2 receptor, the adrenergic alpha 2 receptors here. There's also presynaptic receptors. They can also take the norepinephrine, where it can reduce the concentration of the norepinephrine here in the synaptic cleft. As a result, intracellular responses can be reduced. So these are the synthesis, the various synthesis, the norepinephrine, then the uptake into the storage vesicles here, then the release of the neurotransmitters, and this released is mostly stopped by the gonethidine, and binding to receptor sites. They also the postsynaptic receptor is activated by the binding of neurotransmitters, and the removal of the norepinephrine. This is also released of norepinephrine is rapidly taken into the neuron. This is this one, And this is mostly inhibited by the cocaine and amphetamines and the SNRIs, inhibited this reuptake. So as a result, here the norepinephrine synthesis will be high concentration will be high, and the intensive responses can be produced. And the last is the metabolisms that is mostly stimulated by the methylated count or by the oxidized and monoamine oxidase enzymes. This is another view of the synthesis of the norepinephrine adrenergic. So you can see the tyrosine. And these are the enzymes that is responsible. Dopamines, the vesicles, and then mostly they stop this reuptake to the vesicles. Physical uptake is stopped by this guanethidine, reserpine and guanethidine, and the release of this is stopped by the guanethidine. And the reuptake, the norepinephrine reuptake is also responsible for systems. Some are reuptake by the alpha receptors. While the effector agonist, whenever it goes to the effector agonist, the beta, the alpha receptor, they will produce the physiological responses. While this is the metabolism is mostly occurs by the amino oxidases as well as by the count. Similarly, here this is also the varicosity of the noradrenergic neuron showing synthesis and storage of norepinephrine. We can start from here. The dopa passes through there, vesicles formation occurs. This is storage vesicle, then it releases into the synaptic cleft, and it connects to the effector cells receptors. And this is metabolized by the count and monoamine oxidase in the liver as well as the effector cells, as well as the mitochondria. To produce this monoamine oxidases. Whenever it is free inside the nerve fibers, they can be easily oxidized by the monoamine oxidases. So this is another view. You can see this is the steps that is involved in the synthetic pathway of norepinephrine. So this is the phenylalanine. Phenylalanine, you can see, you can just focus the structure. This is very important structure. Phenylalanine hydroxylase comes. So here the hydroxylation, that is when the benzene ring occurs, it forms tyrosine. And tyrosine oxidase enzymes come, they just form the L-dopa. The double hydroxylation conditions here in this benzene ring. Aromatic amino acid decarboxylase enzymes, they convert the L-dopa into dopamine. So you can see the function of the carboxylic group is removed. This is the decarboxylase. The carboxylic group is removed at form of dopamine. And the dopamine beta hydroxylase occurs. So here, beta, this is the beta position of this one. Hydroxylation occurs. So as a result, it forms the norepinephrine. And then the amino group, CH2 in the amino group here is norepinephrine and then epinephrine forms. So amino group, the methyl transferase, the methylation occurs at the amino groups. So it forms the epinephrine. This is the synthetic pathways of epinephrine and norepinephrine. So this is very important, epinephrine and norepinephrine. So they are the similarly the various organ and tissue functions and the receptors, as I did explain in my previous lecture about the beta receptors, the alpha receptor, where it is, and the various effects on the heart, with the eye, bronchial smooth muscles, veins, gastrointestinal tract, uterus, and lipolysis, lipids. The beta 3 receptors are located in the adipose tissues. Heart, we have the beta 1 receptors. So these are the effects. Chronotropic rate, whenever it increases, this is the chronotropic effects. We will discuss this in the cardiovascular drugs. We will discuss this in detail. Contractile forces, inotropic effects, conduction velocity. These are called chromotropic effects. Whenever the rate is increased, we get positive chronotropic effects. When the contractility of the heart muscles increases, is the positive inotropic. And same vice versa, like negative inotropic and negative monotropic. We'll discuss this in the cardiovascular disease. It increases adrenergic receptor responses, it increases. While the cholinergic, the monotropic decreased, no effects on the contractile forces, while the conduction velocity is decreased. Pupil size is mostly they stimulated by the alpha 1 receptors. Construction, adrenergic response is the construction of the radial muscles. This is called mediasis. While the contraction of cholinergic, that was the muscular miosis. Mostly they are stimulated by the polypalpines. Accommodation, no innovations, you conduct ciliary muscle producing accommodation. Bronchial smooth muscle, mostly the receptors, beta 2 receptors. And here the adrenergic response is relaxation, while that is of the cholinergic response is the contractions. And the blood vessels, alpha 1 receptors, mostly located over here. So skeletal muscle containing both alpha 1 and beta 2 receptors, these are their effects. Veins and GIT tract, both they have the alpha 2 and beta 2 receptors. So adrenergic response will be decreased, while that is the cholinergic response will be increased. Increase the GIT motility increased, as you know, the motility in the GIT motility, the diarrhea-like effects can occur in the cholinergic responses. Same as the lipolysis, the alpha 1 and the beta, so the beta 1, beta 3 receptors are here, they also have the beta 1 receptor. Remember, I did explain that. So it increases the cholinergic, no response, no effects of these on if they don't have the cholinergic innervations. Renin secretion is very important. Renin beta 1 receptors are there, adrenoreceptors, so it increases in case of adrenergic responses. And the cholinergic, there is no. But this show the comparison of the adrenergic as well as the cholinergic responses by innervation to the various organs and organ systems. Classification, we can divide the adrenergic agonist into a direct acting cholinergic, as the name indicates. They will stimulate the adrenergic receptor directly. So they act like the norepinephrine and epinephrine-like effects. So they directly stimulate the receptor. These are the drugs: albuterol, arformoterol, squalene, butamine, dopamine, epinephrine, phenoldopaine, formoterols, and some various the salmeterol, terbutaline, phenylephrine. These are the various metaprotinol, isoprotinol is very important. The direct acting cholinergic agonist. Similarly, these are indirect, amphetamine and cocaine. They either maybe this they just interfere with the either the vesicles whenever they are there in the presynaptic terminal, their neurons. So there is a process of the reuptake into the vesicles. Some, as I mentioned, I show that to you. That maybe this is mostly backed by the gonadotropin. Now there is a P. The reuptake into the vesicles, as well as to the release of from the vesicles. Now the release of the norepinephrine is mostly inhibited by certain drugs, certain agents. Direct and indirect acting mixed actions, either they can also act on the receptor as well as the release and the reuptake into the vesicles. So these are the direct. This term is mixed actions. This is the another view of the direct acting cholinergic agonist and antagonist, indirect and indirect acting actions. Characteristic of adrenergic agonists: most adrenergic drugs. These are the derivative of the beta phenyl phenylamines, right? These are mostly the beta phenyl amines. So we have sorry guys, substitution on this benzene ring, as I did explain. Either the ethylamine side chain produces a variety of compound with a varying ability to differentiate between alpha and beta receptor and penetrate the CNS and nervous systems. Two important structure features of these drugs are: number one, number and location. I have a drug substitution on the benzene ring. I will explain that. And the nature of substitution and the amino nitrogen groups, where you can see whenever we have this methylations, so they will increase the affinity for the beta receptor. The A's group and the amino nitrogen groups larger. this amino group, this is very important. Whenever we have the groups, larger the groups, so they will show high affinity for the beta receptors. When it shows later, they will show they will less affinity to the beta, show less affinity to the beta receptors. You can see the structure of dopamine, and the yellow, the structure of several important adrenergic agonists. Drugs containing the catechol rings are shown in yellow. This they have the catechol rings. These are the catechol rings, the yellow one. So they are catechol. They are also called catechol amines. While the other one are the non-catechol amines. They are like the adrenergic and the phenylephrine. They are non-catechol amines. But the point push we can kada methylation for amino group ne methylation group seva kigi. So the affinity to the beta receptors will be increases, right? So this isoproterenol show high affinity to the beta receptors as compared to the epinephrine, and non-epinephrine have less affinity as compared to the isoproterenol. Sympathomimetic amines that contain the 3,4 dihydroxybenzene, such as epinephrine, non-epinephrine, isoproterenol, dopamine. I just shown, as I mentioned, I shown that in the slide, a catecholamine. And have the following properties: high potency. Catecholamine show high potency in directly activating alpha beta receptors. Rapid inactivations by the COMT and amino oxidase enzymes. They are found in the liver, in the mitochondria, inside the effector cells. So they can easily inactivate these catecholamines. So the third is the poor penetration to the CNS. Are polar, as mostly they are polar, and therefore do not rapidly penetrate into the CNS. You know the pharmacology of the polar and non-polar compounds, that why they cannot penetrate into the central nervous system. More water-soluble agents, they can easily be excreted from the body, while the lipid-soluble, they can penetrate. Low molecular size and low high lipid solubility. Most could have some clinical effects, anxiety, tremor, and headaches that are attributable to action on the CNS, though they are considered the side effects of these drugs. We'll discuss later. Non-catecholamines, the compound that, as I mentioned, that lacking of the catechol hydroxyl group, they have high, longer half-lives because they're not activated by the COMT. As you know, as mentioned in the previous diagram synthesis, that the COMT and the monoamine oxidases, they can convert, they can inactivate the non-epinephrine epinephrine into inactive metabolites that can be seen in the body. And these include the phenylephrine, epinephrine, and amphetamines. These are the non-catecholamines, and they are also co-substrate for monoamine oxidases. That is, and does show a prolonged duration of actions. Solubility of many non-catecholamines due to lack of polar hydroxyl groups permits greater access to a CNS. That is totally opposite to that of the catecholamines. They are highly polar. The lipid, they are less polar. They are lipids are increase the lipid solubility of many highly lipid solubles. Mechanism of action: direct acting agonist, indirect acting agonist, and mixed action direct agonist. Like you can see here, indirect action that directly release the non-epinephrine from the vesicles to the synaptic cleft. While direct actions that directly stimulate the receptors here, the postsynaptic receptor target cells receptors, as a result, the physiological responses will be produced. And the mixed actions, both they directly attach to the receptor sites here, the postsynaptic target cells, as well as to inside the presynaptic neurofibers, in the neurofibers. So it can stimulate the these are synaptic space or synapse, and as a result, they can produce them. So this is why they were just classified indirect acting, direct acting, and mixed actions. So you guys must know the differentiations. That's what is indirect action, what is the direct action, what are the mixed actions. So direct with the effectively, so direct with the receptors by effectively. Indirect acting agonist as I mentioned. I don't want to explain this. For example, reuptake inhibit rapid cause the release of nitrogen from the cytoplasmic pools of vesicles of the adrenergic neurons. Direct release nitrogen there. The reuptake of nitrogen. These agents may block the reuptake of nitrogen. Yeah, ho, the reuptake chicken there the scientific that yeah that's stop koi. Oh yeah, the direct release the pre chicken there the vesicles direct release koi. There's like a adrenergic neuron action chicken there the say whether direct agonistic action say why. فهم خبره that triggers the synapse and binds to alpha or beta receptors. Uh, Mostly they increases the indirect action traverses the synapse and bind to alpha and beta receptors. They don't have this kinds of receptors are not directly stimulated. Reuptake inhibitions, an agent that causes night release include cocaine and amphetamine respectively. Cocaine and amphetamines. That's why they have their pronounced actions as they don't, they're not even, they're non-catecholamines. So they cannot, their duration of action is longer as compared to catecholamines. Next action agonist, ephedrine and steroid some of the pseudoephedrines. Both stimulate adrenoreceptor directly and enhance the release of direct actions. So secretary ephedrine except to khushal batubi bronchodilators of that. So that's why the action is the and the beta 2 receptor. Adrenergic agonist they directly bind to adrenergic receptor effector without interacting with the sign of neuron. As a group, these agents are widely used in clinical practices. Epinephrine, one of the four catecholamine, epinephrine, norepinephrine, dopamine, and dobutamine. You guys now they can differentiate between this, the dopamine and dobutamine. Though dobutamine is a synthetic one, and the other one is the natural occurring neurotransmitters. 80% of the adrenaline norepinephrine is methyled to yield epinephrine, which is on the chromaffine cells along with the norepinephrine. And upon stimulation, the adrenaline release about 80% of epinephrine and 20% norepinephrine directly stimulations. 80% epinephrine is found on the adrenaline, but 20% norepinephrine. Yesterday, I did show you that which epinephrine, which receptor have high affinity for these neurotransmitters, epinephrine, norepinephrine. It depends. At low doses, beta effects vasodilation of the vascular system predominates, where at high doses, alpha effects vasoconstriction are the strongest. Epinephrine, this is we are talking about epinephrine. At low doses, they most stimulate the beta receptors. While at high doses, they mostly affect the vasoconstriction effect will be higher, and that is mostly because of the alpha receptors. EVS cardiovascular actions are the cardiovascular system. Epinephrine strengthens the contractility of the myocardium, positive inotrope, as I mentioned. This is the contractility. Whenever it increases, positive inotrope. Whenever it decreases, the negative inotrope. And it increases its rate of contraction. This is the positive chronotrope, beta 1 actions. As a result, if the contractility increases, as well as the heart rate is increased. So heart rate and contractility, they are mostly associated with the blood pressure, the cardiac output. And cardiac output is directly proportional to the blood pressure. So these effects increase oxygen demand on the myocardium. As epinephrine activate beta 1 receptor in the kidney to cause renin release. Renin enzymes that produce or they can get involved in the conversion of angiotensin 1 into angiotensin 2 as a potent which is a potent vasoconstrictor. Therefore, the cumulative effect is increase in systolic blood pressure that is coupled with a slight decrease in diastolic pressure due to beta receptor. The epinephrine constrict arteriole in the skins, mucous membrane, etc. Alpha effect, and then dilate vessels going to the liver and skeletal muscles. While the beta 2 effects, these combined effect results in a decrease in renal blood flow. Therefore, the cumulative effect is an increase in systolic blood pressures coupled with a slight increase in diastolic pressure due to beta 2 receptor vasodilation. Let me explain this one. Pulse rate, this is the pulse rate. Epinephrine increases the rate of force of cardiac contractions. Remember, the rate of force of contractions, as a result, blood pressure will be higher. Infusion of the epinephrine. Blood pressure, as I mentioned, systolic blood pressure is increased and diastolic blood pressure is decreased. That is because of the infusion of epinephrine. Epinephrine decreases the peripheral resistance. Peripheral resistance decreased. So what will happen? The blood pressure will be decreased. Respiratory system, epinephrine causes a powerful bronchodilation by acting directly on bronchial smooth muscles, which are two actions. And this action relieves all known allergic histamine-induced bronchoconstriction in the case of anaphylactic shock. This can be life-saving. Epinephrine is a life-saving, especially in the case of anaphylactic shock. This is because of they mostly is the histamine, the allergic histamine-induced bronchoconstriction. That is the cytokine style, the histamine storms. It can be relieved. In asthmatic attacks, epinephrine rapidly relieves the dyspnea. That is, dyspnea is the difficulty in breathing, and increase the tidal volume. Volume of gas is inspired and expired. You know, guys know the physiology of the tidal volume. And epinephrine also inhibits the release of allergy-mediated substances such as histamine from mast cells. And how about its effects in hyperglycemia? There is significant hyperglycemic effect because of increased glycogenolysis in the liver. Beta-2 effect, hyperglycemia, not hypoglycemia. It increases the blood glucose level, increase the release of glucagon, beta-2 effect, and decrease release of HCG, alpha-2 effect. That's why, because of these, they are termed, they are as a hyperglycemic agents. Decrease the release of insulin. As the beta receptors are present in the adipose tissues, so epinephrine initiates lipolysis through agonistic effect of the beta-1 receptors in the adipose tissue. Increased level of CAM stimulate a hormone-sensitive lipase, which hydrolyzes the triglyceride to free fatty acids in glycerols. So as a result, it can lipolysis. It can help in the lipolysis, the breaking of the lipids. Bronchospasms, it can be used in the bronchospasms, in anaphylactic shocks, right? Cardiac arrest, yes. Cardiac arrest is the sudden stoppage of the cardiac rhythms. Whenever it stops, heart beating stops, so we call it cardiac arrest. Then ka achanak band ho jana. And if anything may be used to restore the cardiac rhythm and cardiac arrest, mostly the drug is directly injected into the heart. Local anesthesia, because why they are doing local anesthesia may contain low concentration. It is in ratio 1:1000 parts of epinephrine, and greatly increase the duration of anesthesia by producing vasoconstrictions. They vasoconstrict the vessels. As a result, the increased duration of local anesthetic drugs that can be higher at the site of injection. So this is most used in the anesthetic drugs, epinephrine, because it causes vasoconstrictions. So as a result, local anesthetic efficiency can be increased, while because of this vasoconstrictions. Vasoconstriction cascade ban ki blood direct anesthetic agent then the duration se vashi. And also used in the glaucoma, especially in the closed angle guide glaucoma, and intraocular surgery escapes the reduction of maintenance of mydriasis. Like people chicken that dilate mydriasis during intraocular surgeries. Pharmacokinetics, the rapidly onset of actions on the duration of lipid impressions. Poor penetration into CNS can be used in aerosols, intramuscular intravenous. This metabolite in the urine. Anaphylactic is outpatient strings and intramuscular anterior thigh due to rapid absorptions. Epinephrine delivered intravenously for the most rapid onset of action. Remember this one. It can also be given subcutaneously by endotracheal tubes or by inhalations, and easily be metabolized by non-amino acids and release in the excrete in the the urine in the form of vinyl mandelic acids. Metanephrenes, metabolite metanephrin vinyl mandelic acids. CNS disturbances may occur like confusions, anxiety, tension, headache, and tremors. Hemorrhages. The drug may produce several hemorrhages as the result of marked elevation of blood pressures. Systolic blood pressure सेवा कई. Systolic blood pressure सेवा कई is also blood brain hemorrhages chances सेवा. Cardiac arrhythmia. Epinephrine can trigger cardiac arrhythmias when the patient is receiving digitalis. And pulmonary edema can also cause by these. Epinephrine can induce pulmonary edemas. Non-epinephrenes is the neurotransmitter in the adrenergic neuron. It should theoretically stimulate all types of adrenergic receptor. However, when administered in therapeutic doses, the alpha adrenergic is most effective. And cardiovascular reactions, vasoconstrictions may occur, right? In Africa, a rise in the peripheral resistance due to intense vasoconstriction of post-vascular beds, including the kidney alpha-1 effects, both systolic and diastolic pressures. And non-epinephrine has got vasoconstriction than epinephrine because it does not include. I think I have a very good slide for this one. Yes, here. Now induces reflex bradycardia, infusion of non-epinephrine, pulse rate. You can see gives a reflex bradycardia. Blood pressures, mostly systolic blood pressure rises. The blood pressure this is also can be raised with that. Causes increased systolic and diastolic pressures. It can increase. While that are the epinephrines, that can only the systolic blood pressure rises. And the peripheral resistance can be increased, causing increased blood resistance. Including a rise in vagal activities. Vagal produce a reflex bradycardia, which is sufficient to counteract the actions of non-epinephrine on the heart. Although reflex compensation does not affect the positive effects. Transmission of vagal penitropine in case of atropine 5, which blocks the transmission of vagal effect, is given before non-epinephrine stimulation of the heart by night is evident as a tachycardia. Okay. Adrenaline, you guys know adrenaline. This is a very life-saving drugs, prototype drug. As I mentioned, 80% of the adrenaline medulla produce this, causing annual endings 20%. Synthesis and PK for clinical use prepared synthetically administered 0.5 ml of 1/1000 solution, subcutaneous intramuscular administered, conjugation of glucuronic and sulfuric acid, and oxidized by the monoamine and the comp, excretion of vinyl mandelic acid metabolites during the evening. Pharmacological action: CNS, restlessness, anxiety, headaches, tremors. These are the pharmacological actions. I dilate people, alpha-1 receptors, and decrease the antagonist due to increased drainage. And sorry, this is not spinning. This is a type of mistake. Sweat glands, increased sweating. Myorectal muscle stimulation alpha-1 receptors, and stimulation of the beta-1 increases the calcium. Transport increases rate, contractility, and conduction. These are the effects that is produced. Coronary blood flow, coronary flow increases due to increased contraction, blood pressure increased. Peripheral vasoconstriction, beta peripheral vessels increase systolic blood pressure, and this skeletal muscle relax, which will lead to diastolic blood pressure increase. Come like you see, closing at lipoma, epistaxis, post-energical venezy, खून निकलना नाक से, anaphylactic shock, status systematicus, cardiac arrest, दिल का अचानक बंद हो जाना, with local anesthetic there can be used. These are the contraindication. Hyperthyroidism की ज़्यादा issues को, density of adrenergic receptor and muscular